Hello, my name is Ivana Bozicevic. Welcome to this session on HIV surveillance. In my presentation, I will focus on four main issues: components of HIV surveillance, steps that have to be undertaken to identify populations at increased risk of HIV, the relationship between HIV prevalence, incidence and mortality, and tools and methods that enable to estimate where new HIV infections are coming from. Firstly, I would like to define disease surveillance. Surveillance is the ongoing collection, analysis, and interpretation of data about a disease such as HIV or about a health condition. The objective of surveillance is to assess the health status of populations, detect changes in disease distribution and trends, define priorities, assist in the prevention and control of diseases, and monitor and evaluate related treatment and prevention programs. The components of HIV surveillance are HIV case reporting, reporting of HIV-related mortality, biobehavioral surveys, sentinel surveillance, size estimation of key populations, and surveillance of sexually transmitted infections. Sentinel surveillance is a type of surveillance activity in which specific facilities such as healthcare centers and hospitals across a geographical region are selected in order to collect HIV surveillance data. Biobehavioral surveys are cross-sectional surveys implemented in populations at high risk of HIV or in a general population and aim to assess HIV prevalence and HIV-related behaviors. In the countries of the World Health Organization European region, HIV epidemics are concentrated in key populations whose behaviors, but also the social and economic context they live in, put them at high risk of HIV. People who inject drugs, men who have sex with men, sex workers and their clients, but also other subgroups such as prisoners and migrants. The most relevant risk behaviors are those associated with the main routes of HIV transmission: unprotected anal sex, unprotected vaginal sex, and use of non-sterile injections or materials. HIV biobehavioral surveys in key populations are used to obtain data on HIV prevalence, levels of risk behaviors, and coverage with various HIV interventions, including prevention and treatment. Due to the lack of sampling frames, these surveys are most often based on quasi-probabilistic sampling methods, such as respondent-driven sampling and time-location sampling. How can we identify which populations are most affected with HIV and where HIV cases are coming from? The first step is to review available literature in a country and data sources such as HIV case reporting, HIV prevalence data from testing services, sentinel surveillance of antenatal care attendees, surveys of the general population, available studies among key populations, and geographical mapping of HIV-positive cases or populations at increased risk for HIV. As the surveillance inventory is developed and the data reviewed, areas where there is more HIV infection and risk behaviors will begin to emerge. The four steps to identify key populations at increased risk are: in each geographical unit, decide which groups are important to track. Estimate the size of populations at increased risk, if needed. For the most affected groups, assess the level of risk intensity based on how frequently these populations engage in unprotected sex or inject drugs, and how big the networks of these persons are. Step 4. Assess the current level of HIV prevalence and incidence among different populations and across different geographical areas in order to prioritize surveillance activities geographically. HIV prevalence by age group should be considered whenever possible. Knowing which age groups have high prevalence rates helps program managers focus prevention efforts. Prevalence among young age groups or among people who recently started injecting drugs may be considered as a proxy for incidence in the population. In most countries, the HIV epidemic is diverse, so trends in prevalence and risk behaviors should be followed in subnational geographical units or epidemiological zones. Now, I would like to talk about the importance of understanding the relationship between HIV prevalence trends, incidence and mortality. HIV incidence is the rate of new infection in a population over time, while HIV prevalence measures the proportion of people living with HIV in a population at one point in time. Despite the importance of incidence as a public health indicator, most surveillance systems have focused on measuring the HIV prevalence in a population. Prevalence is useful as it measures the disease burden but does not directly reflect the rate of current HIV transmission because it can be confounded by other factors such as migration, birth rates and survival, particularly in the context of the large-scale expansion of antiretroviral therapy programs. However, when prevalence data are carefully analyzed by age, sex and cohort, they can be used to assess trends in underlying incidence, particularly in younger age groups. An increasing HIV prevalence might imply that the rate of new infections is higher than the HIV mortality rate. However, this can be also due to a higher number of people living with HIV due to availability of HIV treatment, while the rate of new infections might at the same time stabilize or be on the decline or on rise. Similarly, a decline in HIV prevalence might mean that the rate of new HIV infections is decreasing, but could also occur in a context of an increasing HIV incidence and an HIV death rate that is higher than the incidence rate. As you can see, relations between HIV prevalence, incidence and mortality are complex and depend primarily on the duration of the HIV epidemic, HIV testing practices, patterns of HIV risk behaviors, and availability of treatment. Understanding these relationships requires a detailed analysis of several data sources, including surveillance and prevention and treatment program monitoring. Let us now look into tools and methods that enable to estimate where new HIV infections are coming from. Firstly, let me emphasize that HIV incidence is difficult to measure directly. Even in high incidence settings, which would be above 0.5% annually, or one new infection every year in 200 people, the occurrence of a new or incident infection is a relatively rare event. So very large sample sizes are required to measure it directly. HIV incidence can be estimated using direct and indirect approaches. Direct methods include longitudinal follow-up of individuals who do not have HIV infection, which involves repeated testing of the selected cohort to determine the proportion that has acquired infection over time. Another direct method is incidence estimation using laboratory tests for recent HIV infection. This method can be applied to specimens collected in cross-sectional surveys and on newly reported HIV cases. However, biases can arise due to the potential for long-standing infections to be misclassified as recent, the so-called false recent rate. Another challenge to using this approach lies in the validity of currently available assays. Although about 20 different assays have been developed so far, only 2 have been commercially available. The BED, capture enzyme immunoassay, and the limiting antigen LIG, avidity enzyme immunoassay. Results from evaluation of the performance of the incidence assays suggest that testing for antiretroviral therapy exposure in addition to viral load may further reduce the false recent rate, although research is needed to determine whether this additional testing is recommended. Indirect methods to estimate HIV incidence are based on using prevalence data. The most widely used ones are modeling incidence from serial prevalence surveys, which is used in a tool called Spectrum. Other modeling approaches estimate incidence using assumptions about risk behavior and HIV transmission. Indirect incidence estimation can be also made from HIV prevalence in young, recently exposed populations. This method assumes that in populations in whom the time since first exposure to HIV infection is short, trends in prevalence approximate trends in incidence. For example, trends in the prevalence of HIV in injecting drug users aged 15 to 24 can be used to approximate trends in incidence in the broader population of people who inject drugs. Finally, let me emphasize that an effective response to HIV at the country level requires strategic information that's systematically collected and consolidated, analyzed and applied. The rapid growth of treatment programs over the past decade has underscored the importance and role of strategic information for program planning and evaluation of the impact of HIV programs. Thank you for your attention.